Greetings from the Indian Musculoskeletal Oncology Society. We thank you and welcome you to this first webinar conducted by IMSOS along with OrthoTV. And as a beginning topic, we have decided to cover the common errors we commonly come across in workup and diagnosis of bone and soft tissue tumors. Errors in workup and diagnosis and biopsies are not common to only our country. We have had a lot of publications coming from the Western literature as well. As Zachary in his paper had mentioned, that out of the 116 patients that they came across, 51%, more than 50% had been operated inappropriately. And a very high percentage, almost 92% of his patients were operated without any previous biopsy at all. That leads to a lot of problems. As this paper from Birmingham says, they have a massive data of more than 2,200 patients, which they have analyzed over 23 years, of which a whopping 28% of cases were hoop surgeries, as they call them, which are inappropriately done surgeries for patients with bone and soft tissue tumors. Out of these 363 patients, almost 188, that is more than 50%, again had a residual tumor. And we now know that the risk of recurrence is very high with high-grade tumors and with cases where there are residual disease. The risk of metastasis in these patients is 3 times higher when this particular thing happens. And that is why we need to aim to reduce these particular errors in workup and diagnosis. I'll be sharing with you a few case examples that we have come across at our orthopedic oncology clinic. This is a case of a 35-year-old lady who presented to the orthopedic surgeon with painful swelling in her right ankle. And her X-ray showed a very well-defined lytic lesion in the distal tibia. Well, at the outset, it looks as if it's a very well-defined lesion with narrow zone of transition, no soft tissue extension, hardly any periosteal reaction, and has all the features of a benign lesion. So what our orthopedic colleague did was he did an extended curettage without doing a biopsy, filled the defect with autografts. The patient was okay for the next 9 months, and then she started having pain and gross swelling in that particular operated area, which is seen in these clinical pictures. The X-ray at that time showed a lot of newborn formation, aggressive looking periosteal reaction. A patient had pain, the range of movement was terminally restricted, and the alkaline phosphatase was marginally raised. A fresh biopsy at this particular stage then revealed that this was an osteogenic sarcoma. And then the patient had to be subjected to fresh staging, and she ended up having an below-knee amputation. Another child at 10 years old, this child presented to an orthopedic colleague of ours with a well-defined, eccentrically located metaphyseal lesion in the distal femur, which on the MRI showed multiple fluid levels, which are evident and which are a very classical sign of an aneurysmal bone cyst. A biopsy was not performed at this particular stage, and the surgeon decided to go ahead and do an curettage and filled up the defect with G-bone. As you can see, a few weeks down the line, the lesion keeps on increasing in size. There is a good amount of periosteal reaction now. You can see that there's a Codman's triangle that's forming. The lesion has increased in size. There is intermediate zone of transition. The orthopedic surgeon, however, did not realize that this is something ominous that's going on over there. And he decided that, okay, probably this looks like an infection and I need to go down and curate everything out, clean everything out. And that's what he did. Did again an intralesional surgery without a biopsy, and then put in some antibiotics, so antibiotic impregnated cement beads inside. And when the patient presented to us, this was the clinical picture. A very bad wound, cross disease, badly contaminated extremity. And now this is a situation which is beyond any salvage now. And the patients typically end up doing getting an Avoni amputation done. The lesson that we learn from these cases is that we need to do a biopsy always before doing any major surgical intervention, especially if the diseases are benign aggressive looking or overtly malignant looking. And that's a rule that we need to follow always in our clinical setting. Whenever we do a biopsy, it's important to understand that we need to biopsy following all the biopsy principles. This is a 35-year-old lady who presented with a recurrent lesion in the lateral corner of the femur. again to an orthopedic colleague. That shows a very well-defined lytic area on the CT, X-ray, and the MRI scan. The earlier biopsy report was probably suggestive of a benign lesion, and that's when he decided to go in, do a curettage again, and put in cement. But while doing it, he violated the knee joint, violated two compartments, the lateral and the anterior. And unfortunately, the report in this case again came out to be an osteogenic sarcoma. Now, that's something that we need to remember again, that when we biopsy, we have to follow all the biopsy principles. And we will be taking another webinar, especially on how to do a correct biopsy and what are the biopsy principles that are to be followed when we do that. When a particular patient like this consults us for a massive swelling in the proximal tibia and the knee joint, we need to be very, very careful. Work them up sufficiently, adequately. The X-ray in this particular case shows that there is an aggressive looking lytic lesion in the proximal tibia, which is probably also involving the knee joint. Adequate imaging has to be done prior to any further treatment or biopsy. And as you can see that this is a very, a big neoplasm which is involving the proximal tibia as well as the knee joint. And there are a few lymph nodes in the popliteal region, and there is a lesion seen in the suprapatellar area as well. This needs a biopsy, yes, but then when this was biopsied by an orthopedic surgeon, look where the biopsy scar has been placed. Yes. Now we have this understanding that the biopsy has to be done in from a peripheral area. Now, that is to give us the maximum chance of getting a viable tissue. And once we decide what's the peripheral area is, that we need to be careful and see to it that we are not missing the main lesion per se. That is what happened in this particular situation. The biopsy was done from a normal area of the tibia way down distally and where it should have been, and the patient ended up having an inconclusive biopsy and had to be subjected to a biopsy procedure again. So whenever you decide to do a biopsy, remember that we need to plan, look at the MRI and the imaging, look at the local staging investigations, and then target the biopsy properly, get tissue from the viable area so that we don't get an inconclusive report. Another case, again, a 42 years old gentleman who presented to the orthopedic clinic with a knee swelling, was thought to be having a knee synovitis, probably infective. There is some lysis seen in the proximal tibia. This was not sufficiently investigated before doing a surgical intervention. And then he was subjected to an open procedure, probably a synovectomy, probably an open biopsy. But as you can see that there is a very big scar that runs horizontally on the anterior aspect of the knee joint. And then there are these recurrent nodules which you can see under the scar. This unfortunately later on turned out to be a mesenchymal chondrosarcoma affecting the proximal tibia with an intra-articular extension, as you can see from the MRI images. Doing a horizontally or placing a biopsy scar horizontally on the extremities is a strict no-no. That is what we advocate always, that we need to have longitudinal incisions if you have to do an open biopsy. Otherwise, even a needle biopsy in this particular case would have been good enough. It's always important to remember that we need to do all the local staging, that is the local imaging, prior to the biopsy, including the X-rays and the MRI scans, so that we know where to place our biopsy scars and where to take the tissue from. And we also have to remember that an improperly done biopsy by us may in fact necessitate amputation in quite a few patients. Sometimes lesions can give us a surprise, or rather the biology can throw us a surprise as well, as is evident from this case of a 28 years old gentleman presented with a pinpoint tenderness on the anterolateral aspect of his left tibia. The initial X-rays did not reveal anything, while the follow-up X-rays which were done 3 to 4 weeks down the line showed that there was some lysis in the lateral tibial condyle. This was imaged further, and the patient was found to have a very small lytic lesion on the lateral condyle of the tibia with a little bit of an extraosseous soft tissue extension. Now, it's very important to avoid the greed or avoid the tendency to go in and operate at this particular stage and biopsy this. When this was biopsied, this turned out to be a conventional high-grade osteosarcoma. So one needs to have a very high index of suspicion for any neoplasm, more so for a malignancy. Remember that the smallest lesion may be malignant, and also remember that an earlier diagnosis by you can save the patient's life. Another case, a 17 years old student who presented with a painful swelling around the left elbow. He had a terminally restricted flexion along with an extension lag. And he had history of mild occasional fever and there was no lymphadenopathy. And a plain radiograph of the affected area showed that there was a permeative lesion in the distal humerus with broken periosteal reaction and a little bit of a soft tissue extension. Now, this looks to be reasonably an aggressive lesion on the X-ray. The MRI of the affected area showed or rather confirmed the findings on the X-ray. Again, you can see that there is a periosteal reaction on the MRI, there is a cortical breach, there is soft tissue extension, and all these are pointers towards an aggressive neoplasm. But when this was, the bone scan that was done showed that this patient had a solitary lesion, the uptake was seen only in the distal humerus. But when this was biopsied, it was surprisingly found out to be Langerhans cell histiocytosis, a classical picture on histology. So lesions like eosinophilic granuloma, which are also known as Langerhans cells histiocytosis, may commonly mimic the lesions of osteomyelitis or any sarcoma and are easily can be mistreated or misdiagnosed or overtreated for that matter. Another classical example that we keep on seeing in our kind of practice is this is a 40-year-old housewife who presented with a history of pain in the lower limb. She was seen by multiple orthopedicians and treated for multiple lytic lesions. In this particular case, you can see that there is lysis in the patella and probably the proximal tibia as well. She had a past history of undergoing 7 different procedures at different sites for lytic lesions in cases where she was treated with intramedullary nailings and in certain cases with bone grafting. And as you can see that in this case, she had a lytic lesion in the diaphysis of the tibia with thinning and a slight expansion of the tibial cortex in the mid-diaphysis. The bone scan, the 3-phase bone scan that was done at that time showed that there were multiple lesions in the skeletal system, and the findings, the report said, are compatible with a multifocal aneurysmal bone cyst. Now, a multifocal aneurysmal bone cyst is a reasonably rare condition, and hence we need to give a thought, pause here a little bit and give a thought as to what could be the more common condition. And whenever we come across these particular cases, we need to think about the metabolic disorders. This patient continued having pain at different sites and she was unable to walk and was bedridden until she was seen by us in our oncology clinic and then was found to have a very high alkaline phosphatase level and very high serum parathormone levels. And this turned out to be the classical case of a Brown's tumor of hyperparathyroidism, which was being spuriously treated as multifocal skeletal aneurysmal bone cyst. We need to remember that we should not believe blindly the bone scan reports. The bone scan is incapable of giving us the pathology diagnosis in almost most of the cases. We need to review the diagnosis if the clinical picture, the radiological picture, and the pathological picture is not matching. Once the parathyroid adenoma was excised by an oncosurgeon, this particular lady went on to have complete healing in all the lesions, and she was happy to be able to walk again on her own feet. Another common scenario that we come across in an orthopedic oncology OPD is a case like this. An elderly gentleman who presented with a history of 2 to 3 years of an progressively slowly increasing mass in the anterolateral compartment of the lower leg. Now, this particular gentleman did undergo an imaging prior to the intervention, and this is what the imaging showed, a very large soft tissue lesion in the anterolateral compartment of the leg. Now, this was again thought to be a lipomatous lesion, and an excisional biopsy was done under spinal anesthesia, and it was done in this fashion. You can see that there's been a longitudinal scar. The hash marks of the suture lines you can see are widely placed, and the drain site has been placed quite away, in fact, almost in the anterior compartment of the leg. Now, that actually turned out to be a high-grade soft tissue sarcoma, and this is not a situation that we are happy to see always, because now this is going to need a massive intervention in the form of wide local excision and definite requirement of a plastic surgery flap to cover the skin defect. Added to that is the morbidity that comes along for this particular patient, and also the risk of local recurrence because of the spurious intervention. So remember, friends, that assumption is the mother of all goof-ups. Do not assume anything. Do not assume that a soft tissue subcutaneously located lesion lesion is a lipoma or a nerve sheath tumor. This can be malignant, whatever may be the size, and has to be biopsied and staged appropriately, and then the excision needs to be planned. Another common situation that we see is concerning the pathological fracture. This was a 50 years old farmer who had a trauma while he was traveling on his two-wheeler. It was though trivial. He ended up having a fracture in the proximal femur, and that is what the X-ray looked like. He was imaged. There was some lesion in the proximal femur, as is evident from the MRI scan, with an extraosseous soft tissue component. But this was probably taken as a metastatic lesion given his age, and this was nailed at some other center. A stacked enders nailing kind of a procedure was done. But a few months down the line, this is what he ended up having. Unfortunately, it was still not detected to be a neoplasm, and it was thought to be a hematoma around the fracture site. He ended up having multiple procedures for debridement of the hematoma on the collection, and as you can see from the multiple longitudinal scars in the anterior thigh and on the lateral aspect of the upper thigh. Now, that is a totally unacceptable and unsalvageable situation. And this patient had a very stormy ending, which would have been totally avoided had it been managed in a better manner to begin with. We need to keep a keen eye on the pathological fractures. Remember that we need to biopsy. They are not emergencies as far as management is concerned. Also remember that not all lesions in the elderly are metastatic, and again, always biopsy before you do a definitive surgery for these pathological fractures. Another situation, a 24-year-old gentleman who presented with a painful swelling in the distal thigh, 4 months duration, had mild fever. That is what the X-ray looked like. He was being treated with IV antibiotics. Symptomatically did not improve. This was the X-ray done after 6 weeks, and as you can see that there is a very big soft tissue component anteriorly, posteriorly, medially, laterally as well. There is periosteal reaction which is interrupted. There is some intramedullary lesion which is not very clearly seen on the X-ray. This was imaged in the form of a CT scan, and the CT scan report read it out as an infective process with an abscess collection. And unfortunately, the orthopedic surgeon ended up doing an incision and drainage procedure by both a medial and lateral approach. And this was the clinical picture 2 weeks down the procedure. Again, a situation, this in fact turned out to be an Ewing sarcoma later on after immunohistochemical characterization and the pathological testing. And this was again a situation which was beyond salvage. Again, an appeal to all of you: do not blindly follow the radiology reports. It is high time that we sit down with our radiology colleagues and learn to read all the CT scan films and the MRI films and the X-rays ourselves, and not just blindly follow the imaging pattern. I'll come back to the same paper from Birmingham by Chandrasekhar and his colleagues of 2,202 patients. Remember that when these particular patients are treated inappropriately, the risk of recurrence is high. It's more so with a higher grade lesion, and when the disease is residual, as is the case in more than 50% of these particular patients, the risk of metastasis is 3 times higher in these particular patients. So in fact, by not treating them adequately or not imaging them adequately, and by not following protocols, we are increasing the risk of local recurrence, metastasis, and death for our patients. There is an increased risk of amputation in these patients as well. And also, they require more and more extensive procedures in the form of probably neurovascular reconstructions and plastic surgical flaps to cover the skin defects. We need to have guidelines as far as managing these particular patients are concerned. Like NICE guidelines from the UK mention that all these patients have to be referred to specialty clinics, have to be handled by a sarcoma multidisciplinary team and designated diagnostic clinics. We need to identify specific specialty pathologists and radiologists for sarcoma patients, and the operating surgeon has to be a member of this multidisciplinary team. The chemotherapy, radiation therapy is to be handled by the centers which has been approved by the multidisciplinary team. And that is what the Indian Musculoskeletal Oncology Society has done over the last few years. We have our own guidelines that are now available on our website, that is www.insource.org. We will continue with similar such webinars. The Journal of Bone and Soft Tissue Tumors is our official journal. The website is www.jbstjournal.com, and you can find more information about the management and work of various neoplasms affecting the bone and soft tissue tumors. We do meet. This is a society which is formed by all those who are interested in bone and soft tissue tumor treatment. This comprises of surgeons, radiologists, pathologists, industry people, clinicians, non-clinicians. So please feel free to become a member if you are interested. We meet every year annually at different parts of India. We have our annual meeting, and the next upcoming meeting will be in the second weekend of March 2020, which is going to be in Bangalore. So I take this opportunity to invite you all, and please watch the space for further in-source webinars. Thank you very much for your time and listening.